Thank you very much for your nice introduction, Jagat. And thank you, Samin and Jagat and Anu for inviting me today. And it's a challenge, but I'd like to talk about the development and innovation in cardiovascular health in a particular field that we call Imagenomics. And actually, it's exciting. I will present to you 10 new concepts that have evolved over the last 2 years based on three longitudinal studies that we are doing, and we are getting very interesting information. So we move from disease in the bottom, is okay, we should continue to understand it, to health on the top. Because I think it's time to understand health, that we know much less, I believe, than we know about disease. And then we decided that we should do longitudinal studies starting in children from age 0 to age 100. And we have 7 studies related to these 3 ages. And number 3, new evolving technologies and so forth, omics and genetics and with imaging, artificial intelligence, and so forth. So let me now give you a sense of where we had the problem. First, of longitudinal studies, there is only one that is long-term, that I understand what it is being done. The Cardiology study began in 1985 to 1986. Over 5,000 people, men and women, were enrolled, age 18 to 30. And now follow-up is about 35 years. And they're looking at health and disease, but there is no imaging. So good longitudinal study, but I cannot see objectively what is going on with the arteries. On the other hand, we are very involved with OCT, and actually there's 3 papers came up about 4 weeks or 5 weeks ago. But this is invasive, and the disease is advanced, so it doesn't help us either. So we took off, and we are going to talk about Imagenomics as we develop a number of longitudinal studies based on imaging and genetics. Let me begin to say that the study, I will present 10 concepts, and let me start with the imaging developments. We have developed 2D and 3D ultrasound and CT, which addresses 6 different arterial regions: the 2 carotids, 2 iliofemorals, the aorta, and with CT, the coronary arteries. We are talking about the PESA study, 4,000 individuals between age 40 and age 55, located in a bank in Madrid, Spain. What we found, if you can see here, under age of 50, 2/3 of men already had one of the regions involved with disease, 2 or 3, 4, 5, or 6. This is subclinical disease, as we did with the 2D, 3D ultrasound and CT. And this is women. 50% already under the age of 50 have subclinical disease. So the disease begins early, and it certainly, I wouldn't call, is almost universal. But then we have here, in the PESA study, we have actually 1,000 people that we did positron emission tomography of the arterial system, as well as MRI of the arterial system. And what is interesting is we now beginning to have evidence that these lesions, which is actually inflammation, precedes the fibrotic lesions and MRI. And the data is evolving at the present time. And in fact, let's now look at the imaging together with the risk factors in these 1,000 people that I just presented to you with PET and MRI. And this is the story. More risk factors of Framingham, higher is the disease burden that we have with here is with PET or with MRI. And here in blue is because the disease begins in the iliofemoral region. But now comes the interesting issue. What about inflammation? What we are finding is the inflammation actually begins before stenotic lesions are being identified. And wherever there is inflammation, there is more significant development of plaques, that we begin to see are fibrotic plaques than if there is no inflammation. But even further, if you have a stenotic lesion with inflammation, this progresses more rapidly than a stenotic lesion without inflammation. So concept number one, cardiovascular disease is frequent early in life, is silent, and inflammation is a driving force. This is what we are really seeing. There is no other study that I know, longitudinal study, that is looking with such technology. But here is a very fascinating situation. What we found, this is Framingham, high risk, middle risk, very low risk. How is possible that we have so many people in our study that are at low risk of Framingham and they already have subclinical disease? This is very significant subclinical disease, less significant, but that's what it is. What's happening here? And the findings are fascinating because we thought, well, there are other risk factors and we don't know. I think it's far from that. Let me present to you the data. The data is actually in 3 studies that we have published one after the other, and that is, for example, LDL is considered to be normal below 100 milligrams DL. If you look at subclinical disease, you are absolutely wrong. Subclinical disease is already present even with levels of 60 to 70 milligrams DL. And we look at all the other risk factors. So this is a standardized. This is with LDL, this is with hemoglobin A1C, and this is with triglycerides. And we found exactly the same story. In fact, this is actually hemoglobin A1C. This is a pre-diabetic group. This is the disease, subclinical disease. Pre-diabetes is going to become a very important risk factor. I can guarantee this to you. But it's not the end. This is actually triglycerides. We consider normal triglycerides 100 to 150, which is subclinical disease. So basically, what we consider was normal is completely abnormal. And this is the main problem that we have to come to grips here today. So this is one issue. There is another one, and that is we have 4 people at age 40 with the same risk factors, the same cholesterol level, everything, and then the 4 people go in different directions in terms of prediction. Why is that? Because we didn't take into account what goes on in the first 40 years of life. Remember, guidelines only look from 40 years on. They don't care below age 40. You should take care of the risk factors. That's what they say. Well, let's now go to the Cardiology study. They started here, and we were able to measure the accumulation of exposure to risk factors in the first 40 years of life. And now we are going to show you the answer. And the answer is the following. Here, you start at age 40, but you see people go different directions. What the directions depend from? Very simple. It depends on what happened in the first 40 years of life, which is the area under the curve, and this is just with LDL. Very important. So not only that, we now have, and we submitted this for publication, we found the same with triglycerides, with arterial pressure, and so forth. So 2 things are happening here. First, what we call normal risk factors are not. And second, we completely dismiss what goes on, the accumulation of risk factors early on in life. So this leads to the consideration of the second concept, and that is cardiovascular disease is frequent without obvious risk factors, but 2 things we have to keep in mind. The risk factor levels, what considered normal are abnormal, and risk factors age cumulative, which has not been considered. A very important concept that I think is going to change the way we see people in terms of risk factor profile. Well, let's continue. This led, and now we are dealing with NIH and CDC and other institutions on a trial that we are describing and developing, which takes into account what I told you. This is so-called pre-cut trial design. Basically, individuals between age 20 and 40, those who have blood is drawn, risk factors, and if there is an LDL higher than 70, are going to be randomized already at early age. And we might start with red rice, statins, and so forth, and the other group will serve as normal guideline-based treatment. And here's the story. What you do is, at the end, you follow, this is young individuals, so the only thing that you can get as an endpoint is progression of disease. And you don't have an answer to the secondary endpoint. Of course, it should be the primary, which is events. But we are beginning to have the answer, and let me show it to you. In fact, here, before I gave you what's happening, cardiovascular disease progression early in life, the pre-CAT study is very strict. We take LDL below 70 milligrams DL as normal, and this is the trial where it started at a young age. And now I'm going to get into the cardiovascular events. We just obtained this 3 weeks ago, and it's the data from the bioimage study, 6,000 people between age 55 and age 100, close to age 60 to 100, which we follow the same technology I presented to you on the PESA study. Now we have 12 years of follow-up, and it's fascinating, the data. The data is showing, this is in quartiles, the more burden of disease, anatomically speaking, higher is the number of cardiovascular events, particularly mortality. This is much more powerful than the risk factors. This is very critical. To see the disease is the highest risk factor that you can have, and particularly how much disease. And this is just came out, and it's fascinating. It's a 12-year follow-up with imaging technology, quite sophisticated. And actually, we have seen now the same thing. Let me see if I have the, yeah. This is the calcium score. It's the same, exactly the same thing. Very powerful. Well, this leads to the following concept. Cardiovascular disease mortality later in life by the bioimage study is more significant than just addressing the risk factors alone. This is obvious. Not everybody who smokes develops disease. But if you see the disease, this is a high risk factor. And this is actually what we are seeing with these longitudinal studies. Well, let me proceed. What do you do? Well, what we have done is a number of studies that are based on two basic principles. First, individualized approach. Excuse me. First is the individualized approach in which we say, well, phone calls, pamphlets, and going over in a randomized fashion. And this is on the top. This is a study actually done in Kenya, but it's just as an example. And in the bottom is group therapy, which have done 3 studies already in group therapy. Here's the question. The question is, with all these risk factors and the subclinical disease, can we motivate people to change lifestyle? I'm not sure if there is a center in the brain that tells you what to do, but motivation is a good pathway in what to do. And that's what we have done. Now let me show you the data that some is published, some is not published yet. But this is what we are finding. What we are finding is, in the individualized approach, for example, what we have, fantastic. But then people begin to go down, despite of all the interventions that you do, and that is, you get tired of it, and then you have to do a reintervention. So as humans, sustainability in terms of the disease that we are talking about doesn't work. You have to do it again. And actually, this is fascinating because we are dealing something I'm not presenting here today with children, 50,000 children that we are randomizing. And the basic principle is they do the same thing after an intervention between age 3 to 6. And now we are going to do a second intervention comparing those who had the first and those who start at age 10. And our hypothesis is the results will be significant of benefit, those who were intervened before. It's like the memory comes back and will be exponential. And we have already 50,000 children around the world that we are all randomizing with this particular concept. What about group therapy? Well, this is very interesting because what we did is the control group, we told them over a 10-hour period what they should do. So they knew they were controls, and the others met 10 people. They meet every month, and they talk. You are obese, I smoke, I help you, you help me. And actually, the results of the intervention are actually pretty good, as you can see. But what happened? It goes down. What is fascinating is the group that knows its control but has been trained into a better lifestyle, but there is not group therapy, they do very well. So what we are beginning to see is not only we have to reintervene on people, but is to create a culture and around people, not individual. It seems the way to go. And actually we have a project called University Family, in which we are now getting into the families of people, and we are starting with a research group at CINIC in Madrid, 400 investigators in which they have their families, and we are going to get with panels that affect teachers, the grandparents, the parents, the children, and the grandchildren. So the culture is the answer. Sustainability is quite difficult. So basically, the concept is cardiovascular disease and lifestyle modification is transient and requires re-education. Basically, what I'm talking about is sustainability. But I think the hypothesis that will be exponential result when you do the second time, I think is quite appealing, and we are now getting into this. Well, this is what I wanted to tell you about imaging, but there is another issue that is genetics. Dr. Levy will be talking to you a little bit later, and that is to what extent the disease that we are dealing has a significant genetic component. And now what I like to present to you is something that has evolved over the last few years, which is interesting. We were involved with the ARIC group, with the Boston, the Women's Health Study generated in Boston, with the Malmö study in Sweden, and we have the bioimage study. Bioimage study is the study I mentioned that we have 6,000 people between age 60 and 800. So what it was done is to pick up a number of genes that in the literature were associated with atherosclerotic disease. And there were about 60 genes. And then we have 55,000 participants. This is the study how it started. We are talking about 2016. And actually what you see on the left is the risk factor profile is on the genetic mutations that you see. You quantify that and you say high risk, middle risk, and low risk. And here what we have in the vertical axis are either events or in our case, progression of disease. And there was a relationship. On the right, on the other hand, are the risk factors, the conventional risk factors. Obesity, blood pressure, cholesterol, diabetes, smoking, lack of exercise, and poor diet. And here you have, and also you have a risk profile. What was interesting is there was no close relationship between one group and the other. You can say, well, the guy who smokes has a genetic predisposition. Well, whatever it is, at least with the genes that we looked at, these are quite separated, but there's one issue. In the United States, 98% of people had at least one risk factor. So you may have a high risk, genetic risk, but you still, if you treat the risk factor, and in our case, actually it was hypercholesterolemia, you may have a significant result of a decrease in cardiovascular events with no relationship between genetics and the risk factors. Still, if you have a high genetic risk, take care of the risk factors because the results can be of benefit. This is actually what was in, we are talking about 2016. Now we are here 2017, and something becomes very explosive. It's the so-called the clonal hematopoiesis of indeterminate potential, CHIP. And the issue is quite fascinating, is that, well, there's a lot of inflammation in atherosclerotic disease, but where the inflammation comes from? And we know the bone marrow plays a very important role. But maybe the monocytes that come from the bone marrow are already mutated. And rather than saying this is an inflammation that takes care of cholesterol, you might say these are abnormal genes that actually betray you coming from the bone marrow that is mutating. This is the concept of CHIP. I'm sure Dr. Levy will be talking about this in a moment. So, and actually we wrote this article, is Dr. Levy, I think is the first author in the article, is that he's beginning to look at the cells in the circulating blood, looking at CHIP, mutations of the cells that actually come from the bone marrow that might have implications in the atherosclerotic disease that I am mentioning? Well, we and others have seen something very fascinating, and one of the genes, the TET2 gene, could be quite important into what we are talking about, a specific gene that is a defense mechanism, as you will see in a moment, that if it is mutated, can lead to trouble. Well, these are the studies. We were actually involved in the study on the left, and this is the study on the right. Very basically, this is actually the murine model, in which basically if there is significant deposition of cholesterol, if TT2 is mutated, is bad news. What TT2 appears to do is to prevent the damage to go further, and is a protective gene. If it is not protective, the fat keeps accumulating, or the macrophages actually keep accumulating. This is on the left. And on the right is TET, or TET2, appears to prevent the intimal hyperplasia in the atherosclerotic process. So if it is mutated, it's bad news. So now the whole concept is this chip from the bone marrow, maybe the cells are transformed in the sense that mutations that are defense mechanisms end up betraying you, which is a different concept than the one we had in the past, and that is this cholesterol, too many macrophages taking care of the cholesterol may be overwhelming and actually creating a problem. Well, with this in mind, now it's very fascinating. We have all of this in vivo, and this is where this has not been published yet. But basically, in the 1,000 people that we did PET, we were able to see how the bone marrow was reacting with PET and what happened with MRI and PET in the peripheral circulation. And actually, it's interesting. Here you have positive bone marrow. The bone marrow is activated, and what was seen, this is the disease. We do PET and MRI in the peripheral arteries. It was a very close relationship between the activation of the bone marrow and the inflammation in the lesions in the arterial system. So what we are thinking is maybe this concept of chip is quite important. And once the bone marrow is activated, many cells may get out and actually go into the arterial circulation and induce damage rather than the opposite. And here comes a puzzle. We correlated this with risk factors, and what we found is the metabolic syndrome, obesity, and hypertension, for example, they correlated very much with bone marrow activation. And here's a key question. Are these risk factors perhaps activating a bone marrow that it makes you sick in the arterial system, in addition to the risk factors affecting the arteries directly? This is a very important question, but these are the findings. So actually, I'd just like to say that the concept 6 to 9, I mentioned the genetic risk, I mentioned chip, I mentioned TET2, and I mentioned the bone marrow implications in vivo with the risk factors. And now let me finish by presenting to you the puzzle of inflammation, and Dr. Lee may agree or disagree. The inflammation is very complex. If you go to the inflammasome, it's a bunch of variables and proteins that are actually involved that is very difficult to say, well, I should give colchicine, I should give this or that. There are so many pathways of inflammation that stimulate the bone marrow and so forth that is a puzzle. So I just wanted to say to you the complexity of the issue. So I'd like to say the following. Inflammasome therapeutic modifications is the way to go. The question is, what pathway do you choose? And this is actually quite complex. So I'd like to finish by saying to you that what we discussed basically today is the Imagenomics. This is the way I would like to present. But we didn't discuss many things I would love to discuss, and we have data actually on artificial intelligence. I already mentioned innovative therapeutics in young people, the study that we are now developing that I presented to you, and I didn't mention single-cell multomics. I'm sure Dr. Levy will talk about it. So I'd like to just finish by saying the following. Cardiovascular disease is frequent in early life, silent, and is inflammation-driven, at least in great part. Cardiovascular disease is frequent without obvious risk factors, but Part is because what we consider normal is not, in part because we don't take into account what happens cumulative in early stages of life. In terms of cardiovascular disease progression, early in life, we have the pre-CAT study with very strict low LDL cholesterol levels to enter into the trial. But taking into account that cardiovascular disease mortality later in life by the bioimage study is more significant than risk factors. So when we have the pre-CAT study, we are going to match the burden of disease later in life that leads to events with the burden of disease earlier in life to predict. That's what we are actually going to do. And then the issue is cardiovascular disease and lifestyle modifications is transient, you need re-education. And in genetic risk, CHIP, TET2, bone marrow, very fascinating new areas. And inflammasome therapeutic modifications is perhaps complex. I just finished by saying to you that I presented what I think in 2020, 2021 are 10 new concepts that have evolved from longitudinal studies and certainly very sophisticated imaging technology. Thank you very much for your attention.